You did everything right. You took your pill every single day, used protection, followed every instruction on the label, and yet here you are staring at a result you never expected. Here's what nobody tells you: birth control fails far more often than the package suggests, and millions of people experience this every year. So, what actually happens next, and what are your real options? Let's start with something that might genuinely shock you. According to the Guttmacher Institute, over 45% of unintended pregnancies in the United States occur in women who were actively using contraception at the time they conceived. Nearly half. That means this isn't a story about careless people or irresponsible choices. This is a story about biology, human behavior, and a gap between what we're told contraception does and what it actually does in the real world. And once you understand that gap, you stop blaming yourself and you start making smarter decisions. The very first thing you need to understand is the difference between perfect use and typical use, because this distinction explains almost everything. Perfect use means using a contraceptive method exactly as directed, every single time without any errors whatsoever. Typical use means how real people actually use it, with missed doses, occasional mistakes, and real-life interruptions. The birth control pill, for example, is 99.7% effective with perfect use. That sounds incredibly reassuring. But with typical use, the way most people actually take it, that number drops to around 91%. That means roughly 9 out of every 100 women using the pill will experience an unintended pregnancy within a year. Male condoms follow a similar pattern: 98% effective with perfect use, dropping to about 85% with typical use. The gap between those two numbers is where millions of unintended pregnancies happen every single year. To understand why, you need to understand what these methods are actually doing inside your body. Hormonal contraceptives, the pill, the patch, the ring, the hormonal IUD, primarily work by suppressing ovulation using synthetic versions of estrogen and progesterone. They also thicken cervical mucus to make it harder for sperm to travel, and they thin the uterine lining. Barrier methods like condoms physically block sperm from reaching the egg. The problem is that none of these mechanisms are infallible, and human biology adds a layer of variability that no manufacturer can fully account for. Here's something that rarely gets discussed: body weight can affect how hormonal contraceptives are absorbed and metabolized. Some research suggests that individuals with higher body weight may experience reduced efficacy with certain hormonal methods, though this remains an area of active research. Hormonal fluctuations, gastrointestinal illness that affects pill absorption, and even the timing of when you take your pill each day can all influence effectiveness. Missing a pill by 12 hours isn't the same as missing it by 24 hours, and for progestin-only pills, even a 3-hour window matters significantly. Then there are the human factors, and these account for the vast majority of typical use failures. Taking the pill at wildly different times each day, missing doses and not following the correct catch-up protocol, using a condom that's expired or the wrong size, not leaving space at the tip of the condom, or putting it on incorrectly. These aren't failures of intelligence, they're failures of information. Most people are never properly taught how to use contraception correctly, they're just handed a packet and sent on their way. Now, one myth worth addressing right here: many people believe that taking antibiotics destroys the effectiveness of hormonal birth control. This causes enormous unnecessary anxiety. The truth is more nuanced. The vast majority of antibiotics, penicillin, amoxicillin, azithromycin, most of what you'd commonly be prescribed, do not meaningfully affect hormonal contraception. The one significant exception is rifampicin, an antibiotic used primarily to treat tuberculosis and meningitis exposure. Unless your doctor has prescribed rifampicin specifically, your regular antibiotic course is not destroying your birth control. That said, if illness causes vomiting or severe diarrhea, that absolutely can affect pill absorption, and that's when backup methods matter. So let's say something goes wrong. A condom breaks. You realize you missed 2 pills, you had unprotected sex, and now you're worried. What's actually happening in your body, and how much time do you have? Once ovulation occurs, the egg is viable for only 12 to 24 hours. Sperm, however, can survive inside the female reproductive tract for up to 5 days. This means that unprotected sex doesn't have to coincide exactly with ovulation to result in pregnancy. Sperm can wait. If fertilization occurs, the fertilized egg takes approximately 6 to 12 days to travel down the fallopian tube and implant into the uterine lining. This implantation window is crucial, because pregnancy technically isn't established until implantation is complete. The hormone HCG, human chorionic gonadotropin, the one pregnancy tests detect, only begins to be produced after implantation, and it typically takes about 10 days post-fertilization before it's detectable even with the most sensitive tests. This is exactly why the next 72 to 120 hours after a contraceptive failure are so important. Emergency contraception, commonly called the morning after pill, works primarily by delaying or preventing ovulation. It does not end an established pregnancy. This is one of the most widely misunderstood facts in reproductive health. Emergency contraception is not an abortion. If you have already ovulated and the egg has already been fertilized and implanted, EC will not affect that pregnancy. It works upstream of that process, by preventing ovulation from happening in the first place, or by affecting cervical mucus and potentially interfering with fertilization before implantation occurs. The most widely available form of emergency contraception is levonorgestrel, sold under brand names like Plan B or the morning after pill, available over the counter in the US, UK, Canada, Australia, and most of Europe without a prescription. It is most effective when taken within 72 hours of unprotected sex, but it does still offer some protection up to 120 hours. That's 5 days, though efficacy decreases with time. There is, however, an important caveat that is almost never mentioned at the pharmacy counter. Levonorgestrel EC may be less effective in individuals above approximately 165 to 175 pounds. The research on this is still evolving, but if this applies to you, a better option may be ulipristal acetate, sold as Ella, which maintains more consistent effectiveness across a wider weight range and is equally effective right up to the 120-hour mark. Ella requires a prescription in the US, but is available over the counter in several European countries. The most effective emergency contraceptive of all, however, is the copper IUD. When inserted within 5 days of unprotected sex, it is over 99% effective at preventing pregnancy. The copper IUD works by creating an environment that is hostile to sperm and interferes with fertilization. It also has the significant bonus of providing highly effective ongoing contraception for up to 10 to 12 years afterward. The downside is that it requires a healthcare provider to insert it, and access depends heavily on where you live and your insurance situation. If you can access it, it is by far the most reliable post-failure option available. Now let's talk about what happens when emergency contraception wasn't used or wasn't effective, and you find yourself with a positive pregnancy test weeks later. First, take a breath. The emotional experience of discovering an unintended pregnancy after contraceptive failure is complicated and valid. Shock, fear, confusion, grief, and even sometimes unexpected joy, all of these are real, and none of them are wrong. What matters most in the first days after discovery is accurate information and access to proper medical care, not judgment from anyone, including yourself. The first practical step is confirmation. A home pregnancy test using first morning urine is highly accurate from around the time of your missed period. If you test earlier and get a negative result but your period still doesn't arrive, test again 48 hours later. Because HCG levels double roughly every 2 to 3 days in early pregnancy, and a test taken too early can miss it. Once you have a positive result, a healthcare provider will confirm gestational age through a blood test measuring HCG levels and typically an ultrasound. This matters because the options available to you and the timing for each depend on how far along the pregnancy is. In terms of your options, there are 3 paths, and all 3 deserve honest, judgment-free discussion. The first is continuing the pregnancy, if this is the path you choose or are considering. The most important early steps are starting a prenatal vitamin containing at least 400 micrograms of folic acid, immediately scheduling your first prenatal appointment, ideally by 8 to 10 weeks, and eliminating alcohol, tobacco, and any medications not cleared by your doctor. Unexpected pregnancies can and do become deeply wanted ones. Your feelings at the moment of discovery do not determine the rest of the story. The second option is adoption, which exists in multiple forms, including open adoption, where the birth parent and adoptive family maintain some form of contact, and closed adoption. Birth parents in the US, UK, Canada, and Australia all have legal protections and the right to receive counseling and support throughout the process. This option is chosen less frequently than the others, but it is a valid and meaningful path that deserves to be on the table without stigma. The third option is abortion. Medical abortion, using a combination of mifepristone and misoprostol, is approved and effective up to 10 to 12 weeks of pregnancy, depending on the country and clinical guidelines. Procedural abortion options are available at later gestational ages, depending on location and circumstances. The legal landscape for abortion varies significantly by country and within the United States, by state following the 2022 Dobbs decision. In the UK, abortion is legal up to 24 weeks. In Canada, there are no federal gestational limits, though access varies by province. In Australia, laws vary by state, but abortion is legal and accessible in all jurisdictions. Regardless of your location or circumstances, the most important thing is to consult a licensed OB/GYN, midwife, or reproductive health clinic, not social media, not online forums, for accurate information about your specific situation and what's available to you. Before we move on, there is one complication that must be named clearly because it is a medical emergency: ectopic pregnancy. An ectopic pregnancy occurs when a fertilized egg implants outside the uterus, most commonly in a fallopian tube, and it occurs in approximately 1 in 50 pregnancies. It cannot develop into a viable pregnancy, and if left untreated, it can cause the fallopian tube to rupture, which is life-threatening. Symptoms include sharp or stabbing pain on one side of the pelvis or abdomen, pain that radiates to the shoulder tip, dizziness, and fainting. If you experience any of these symptoms after a positive pregnancy test, particularly severe one-sided pelvic pain, seek emergency medical care immediately. This is not a wait-and-see situation. It's also worth noting that if you discover a pregnancy while still using a hormonal contraceptive, the reassuring news is that studies do not show a significant increase in birth defect risk from early hormonal contraceptive exposure. However, you should discontinue use immediately and speak with your doctor. If you have a copper IUD in place when pregnancy is confirmed, there is an elevated risk of miscarriage if it remains in place, so medical guidance on removal is urgent. Let's quickly bust a few more myths that continue to circulate widely. First, you cannot get pregnant during your period. False. While the probability is lower, sperm survive for up to 5 days, and women with shorter cycles can ovulate soon after their period ends, making pregnancy entirely possible. Second, the withdrawal method doesn't work at all, also not accurate. With perfect use, withdrawal is about 96% effective. With typical use, it drops to around 78%, which is admittedly not great, but it's not zero either. Third, using 2 condoms at once provides double the protection. This is actually dangerous. Double condoms create friction between the layers that dramatically increases the chance of both breaking. 1 condom used correctly is always better than 2 used together. Fourth, birth control causes permanent infertility. This is false. Fertility typically returns within 1 to 3 menstrual cycles after stopping most hormonal methods, though it can take a few months longer for some individuals after stopping the injectable contraceptive. So what can you do going forward to significantly reduce the risk of failure? The single most impactful change most people can make is consistency. If you use the pill, set a daily phone alarm for the same time every day, not a range, not roughly the same time, but the same time. If you use condoms, learn and practice correct application, check the expiration date, and store them somewhere that isn't a wallet or a hot glove compartment. Heat and friction degrade latex over time. If you've experienced a contraceptive failure and want a more reliable method going forward, long-acting reversible contraceptives, LARCs, are the gold standard. The hormonal IUD, copper IUD, and the implant called Nexplanon all